CEO of the eHealth Initiative and Foundation. If you're just joining us, welcome. It's great to be here with you today. We have a fantastic program today talking about patient matching, and we're going to tackle it from a couple of different stakeholder sides. Really delighted to share all these different perspectives, and it's great to have folks from all over the country with us here today. We do want to get to your questions, and we want this to be somewhat of an informal discussion today. So we are anxious to hear what questions you are having. I know we've had a number that were submitted through the registration process, so we have those questions in advance. But if things come up today while the speakers are expressing their different perspectives, please feel free to go to that Q&A box below and just go ahead and submit your question there. If somebody's already posted your question, you can see all the questions that have been posted by clicking on that Q&A box. And we have something called an upvote. So if you see a question and you're like, gee, I really want to know the answer to that, put a thumbs up there. And if we have a number of folks who have the same question, we will make sure we get to it. So please feel free to do that. Next slide. As I mentioned, we've got a great group with us here today. We've got Dr. Eric Rogers, who's the Chief Medical Informatics Officer with the Marshfield Clinic Health System. We have Desla Mansilla, who's the Business Lead of Health IT at the Blue Cross Blue Shield Association, and the wonderful Courtney Timmons, who's the Director of Market Strategy at LexisNexis Risk Solutions. All folks who are working on this patient matching issue and have a lot to share with us today. So we're going to hear some thoughts from each of them, and then we will go to some Q&A and wrap up within the hour. Next slide. And there are wonderful photos of our crew today. Welcome. And we also have them live here on your right. Next slide. For those of you who are not familiar with the eHealth Initiative and the Foundation, we are a nonprofit here in Washington, D.C., and this is just a sampling of some of the executives that we work with. We work with folks from across the spectrum of healthcare. We really pride ourselves on the fact that we have payers, providers, labs, vendors, academics, researchers, all different folks who are tackling the issues of healthcare transformation through technology. And if you do not see the name of your company or your logo up there, then you need to join us. So I would encourage you to feel free to send me a note through the chat today, and we will reach out to you and get you some information about how you can join our group and get engaged. Next slide. We do education, advocacy, and thought leadership. You've probably seen some of our emails about our upcoming programs. We've done a lot of policy recommendations over the last 18 months as well. And we have a number of thought leaderships and reports, which we have been pushing out. If you go to the next slide. The critical areas that we work on are consumer privacy for health data, virtual care, analytics, and COVID-19 right now, as everybody's working on COVID-19. Next slide. This is just a sampling of some of the most recent forums and webinars. Because we're a nonprofit, all of these programs are available to you free of charge. We encourage you to share this information, share the videos, share the slides, collaborate with each other on our resource center on the web at ehidc.org. Next slide. And this is just a sampling of some of the publications. We put out a number of really valuable reports over the last year around COVID-19, social determinants of health. We've done a lot of work looking at tribal communities and how they're using SDOH around COVID-19. We have a set of guiding principles about the ethical way to use SDOH data. We've done a lot of work, as I mentioned, around recommendations around COVID-19 and SDOH, and we have a lot more coming in the near future. So I encourage you to get engaged. Next slide. And I do want to thank LexisNexis, who's been a staunch supporter of our work around social determinants of health over the last 2 years, really, and has really been a key player in this area. So I do want to thank them for their support. Next slide. And I want to thank everybody for joining us today. So let's jump into the conversation now. We're going to actually kick it off here with Eric Rogers. So we're going to disappear for a few minutes here, Eric, and thanks for joining us. Tell us what you're thinking about patient matching.
All right. Well, thank you so much for that introduction, Jen. I'll do my best to live up to it. I'll just give a little bit of background. It's true. I am a CMIO for Marshfield Clinic Health System. We're up in central and western Wisconsin. But my day job and my initial training was as an emergency physician. So patient matching and this idea of patient matching in the emergency department, I find has always been sort of a front and center issue. If you think about it, obviously, the obvious segue into that would be when you have the unconscious patient roll into your emergency department, and maybe you have a name and an address, maybe you don't. But the idea that there could be some way to know some background on that patient, whether it be past medical history, ideally allergies, current medications, et cetera, has always been very enticing. And that's a very real and palpable example every day in the emergency department. The obvious example of that, as I said, is the unconscious patient. But I also think that it's important to point out that as physicians and providers in healthcare, there's certainly a great deal of difficulty sometimes conveying information to a patient in a way that they can truly absorb and then be able to reiterate that. I'm oftentimes amazed at how much I personally have struggled trying to convey information in a manner that my patients would then be able to walk into another room and explain to another healthcare provider. So I think this idea of interoperability and patient matching really has the potential to absolutely take us to a new level in healthcare. And I think in the end, it's really an opportunity for things to truly improve. Now I say that, and it's interesting because I think this particular forum and a lot of the people here provide a great example of why this is going to be more and more important to begin with. Specific to the emergency department, most people don't tend to shop around for the emergency room next door or go across town if they have a certain complaint, at least most of the time. And as things sort of open up now post-COVID, and as more and more people are going to be working remotely, I think it's going to be more and more frequently that patients are going to have care that's sort of scattered. It's not a new idea that somebody might go to a certain healthcare entity if they wanted a certain type of cancer treatment or a certain surgical treatment. But the idea that now somebody might spend a year working in the Southwest when their primary location is in the Northeast, and they might need healthcare then, and sometimes on an emergency basis, is always where I tend to think of this being sort of a front and center issue. Now, clearly I'm biased being an emergency physician, and that's sort of the one way to look at this as well. Wouldn't this be great for the doctors? That being said, this is a deceptively simple term to describe an incredibly complex idea that sort of iterates or sort of illustrates how this would have to be a two-way street for that to work. So it's a two-way flow of information, and it obviously ties into quite a few different areas of our healthcare system. And what I'm sort of getting at is that, this is all tied in with the idea that a patient's medical record is really theirs, and it's really more their property than a particular healthcare entity's property. And that's sort of a very recently shifting change, and I think we're going to see that dynamic change over the next few years, mostly as a result of the 21st Century Cures Act. And I think it's going to be quite a different perspective, and it's going to lead to a much different paradigm for us as doctors and healthcare providers in terms of what we are, how we're going to view the information that we record and share with our patients. So with that, that's sort of my personal take on the provider impact, some of the potential pitfalls, and really, as I see it, a lot of the potentially fantastic opportunities for this to really empower patients and to streamline and really improve patient care for all of us down the line. And I think that's our, I think that's clearly the way that things are headed, but it's going to be an awfully interesting and fun next few years as we sort of shift our ongoing paradigm from that perspective. And so with that, I will turn it back over to Jen and our next panelist.
All right, thanks so much, Eric. And I really appreciate you sharing those viewpoints because I think it is a different perspective from the clinician's point of view. So thank you for doing that. And I know we've already got some questions in for Eric, so we will get to those. I want to shift first to Desla first so we can hear kind of the payer point of view on this. So Desla, thanks for joining.
Great, thank you very much. And it was really great hearing that kind of consumer focus because that's really what this is all about in the long run. And I had to laugh when I was listening to Eric. I've been in the world of matching to members or patients in some way since the 1980s, when all patient matching was done on tiny little cards within a single hospital. You can imagine the difficulty, but then now when we're talking about the world of exchange across so many multiple entities, it's hard to fathom how we're at this stage and still working with some of the methods that we do use today. So in order for me to explain a little bit about the processes that we use, I think it would be useful or helpful to talk a bit about the structure of the Blue Cross Blue Shield system and the Blue Cross Blue Shield Association's role in the system in order to set some better context here. The Blue Cross Blue Shield system has an unmatched scale and market share while being available in all 50 states and covering 1 of 3 insured Americans. To achieve this level of capability, the Blue Cross Blue Shield system is comprised of 35 locally owned and operated plans and other organizations, including the Blue Cross Blue Shield Association that I work for, which supports the individual plans in a variety of ways. So to this end, I want to share a bit about the Blue Cross Blue Shield identification matching process that ultimately supports the broader goal of health information interoperability. And again, as I was listening to Eric's words and him talking about the experience from the provider perspective, when we really think long term, we really are looking at the impact of being able to match across the entire spectrum of providers, payers, and others with legitimate interests in health information. And long before interoperability was kind of the in thing, and I don't have to use air quotes, you can actually see me. So I am using air quotes for you to see though. And long before it was really the in thing, I think the Blue Cross Blue Shield Association board, or actually the Blue Cross Blue Shield board, understood the value and the importance of linking an individual's healthcare experience over that wide spectrum. And we know that that wide spectrum continues to grow, particularly as all types of health monitoring apps are being developed. And we're not yet sure where that future will lead with all those things. But in part, I think that early awareness of the value of interoperability across the Blue Cross Blue Shield system was because of the fact that we really represent a microcosm of the healthcare industry, since we do have those 35 individual plans, each with a little bit different approach, and who each at various points do need to share member information with one another when it's supported by HIPAA. So this has been a challenge that we've been grappling with for quite some time. And that's where our MMI, or what we refer to as our Master Member Index or Identifier, solution comes into play. I'll talk a bit more about that in just a minute, but I wanted to share those 3 underlying principles that the BCBS board expressed years ago in the early steps of our journey toward interoperable health information exchange. The first of those principles, and again, I was very glad to hear Dr. Rogers' words that matched very closely to ours, the fact that we know that the healthcare consumer or patient owns their information and should have the ability to access it and use it however, wherever, and whenever they need it. But in order to make that happen, another principle that we're really committed to is the standardization of exchange of information processes. So of course, like many of you, our organization is heavily involved with HL7, a standards development organization. And then finally, we understand there are limitations that sometimes exist when health information makes its journey across organizational boundaries. And we think about that in terms of the idea of data liquidity. And I again think that that was a kind of early nod to the idea of information blocking that later came out as a part of the 21st Century Cures Act. And today, here in the payer community is a big day for us. So we really can't have a discussion of interoperability without thinking about the new CMS Interoperability and Patient Access Rule that becomes enforceable tomorrow. So this has been a big deal for the payer community. Shortly, this will be followed by new regulations that will also take effect on January 1st of 2022 under the payer-to-payer exchange requirements. The overwhelming majority of our Blue Cross Blue Shield plans do offer services that fall under the regulated service lines, which are essentially government-funded programs like Medicare Advantage, Medicaid, CHIP, and QHPs that are on the federally funded exchange. So this is an area that we've been paying close attention to. And when it comes right down to it, when we're talking about interoperability, the very first thing that has to happen is we have to know that we're sharing information on the right person. So this idea of person matching is something that's really important in this process. And that's where that MMI tool comes into effect that I referenced a little bit earlier. So our MMI is similar to what in the provider community most organizations refer to as a master patient index. And when I think about this, and we've been starting to think about the terminology a little bit differently. We refer to it in the payer organization as member matching, providers refer to it as patient matching, but the reality is that if we think about it more broadly as person matching as a term, it's probably more appropriate because we know that the people that we are seeking to identify appropriately are not always patients. And this is especially true as we're moving into a world where more and more data is being collected remotely. Again, we think about all those patient-generated data apps through things, health and fitness apps, as well as other things that at some point in the future may well become integrated into a true longitudinal record. I want to talk just a little bit about the detail of our matching solution. There'll be much more technology than I'll be able to share, but in general, it's a person-centric solution. It doesn't change. So once a number is assigned to an individual, that number is related across all of our plans. It's really an enabler for us to have greater payer health information exchange. And it's also important to mention that currently this process is a back office function for us, meaning that we don't share the member identification number on cards of the patients, and it's not used for any purpose other than matching across the system. But on the back end side, in sharing information with the association, all of the plans essentially send us using a secured method that uses field level tokenization and multi-level security controls. The member matching process has led to us to be able to identify over 130 unique members across our system. And over 12% of our members have had experience with multiple Blue plans. So that's where that idea of us being able to have experienced the requirement for matching across organizational boundaries has really come in handy. And as a high level, the process is that individual plans send us their roster information electronically, and us being the association. Those rosters include some key demographic data fields that you would expect. And the one thing that I can say is in the development process for the MMI tool, we went through a lot of different tweaks to identify what would give us the greatest outcomes. And where we found the most success was once we started using standardized USPS postal addresses, and we attained those through an external referential consumer database. So the information comes into us at the association in the non-standardized form. We do some initial validation And then we send that information on to our referential database partner, who standardizes the addresses and sends them back to us. And then we do a little bit of additional processing before it goes back with the unique number to the plans. We've been able to achieve a 99.5% matching accuracy rate, and this is where we seek to have continual improvement. We had a call a while back where 99.5 is industry best practice by far at this point, but is it really good enough? We know there's a lot of work yet ahead. So I could talk forever, and I already have talked forever, so I'm going to stop at this point and turn it over to Jen to move us forward.
Thanks, Desla. We've already got plenty of questions for you, so we will be back to Desla with these questions, but we're going to hear from Courtney first, who's got a lot of the data that's helping to do the patient matching. So Courtney with LexisNexis, welcome.
Thank you. Just so level set background. So LexisNexis Healthcare, we are a large data firm that help our customers perform patient matching, leveraging our vast set of data and algorithms, solving a lot of the challenges that healthcare organizations are facing in regards to patient matching, and then providing those solutions that really allow customers to protect those records ongoing from unauthorized access. So for many payers and providers, the 21st Century Cures Act has become very real, especially in the context of patient matching. Prior to enforcement of the Cures Act, the primary fear was overmatching, right? Commingling records that shouldn't be, or releasing the wrong record to the wrong person, which could risk a HIPAA violation or worse, mixed diagnosis. So the incentive was to always underlink. Well, now the Cures Act says that if a patient or member requests their record, the healthcare organization must have the ability to share that record via API. And if they're unable to, they have a specified time period to resolve the issue, and if they don't, they could be fined up to $1 million per violation for information blocking. Not to mention the health risks by making diagnoses without complete information. So an example of that would be prescribing a medication without full health history, and you run the risk of an adverse reaction, right? So now there's a penalty for overlinking and underlinking. Therefore, it's not enough to just be good. We kind of have to be great, not just for compliance reasons, but for the safety of the patient as well. So many health organizations have spent a lot of money on their current matching methods, which typically are designed to perform what we call probabilistic matching, where you put one record up against another and compare them side by side in terms of the name matching, the address, phone number, so on and so forth. The problem is that we rarely do the records match due to data quality issues. If you register with one health plan and you register under William Smith, and then the next health plan, you change jobs, you start, you move, your address changes, you start a new company and you register under Bill Smith, right? Same person, but William versus Bill causes data quality issues, sparse data. A lot of people aren't comfortable giving their SSN, and so they don't share that. Change in data due to moving, changes in name due to divorce or marriage. And so this data is constantly changing. So the challenges becomes, how do you overcome these data issues in a way that allows us to effectively and efficiently match? And the answer is rather simple in terms of you get the data, right? And so that's where we really help customers kind of align with their current matching processes, and we help with by inputting that data that's missing to be able to make the match. So what we do, and we come in and we fill those gaps with historical addresses and phone numbers, right? Names, SSN numbers. And we use that data and algorithms that when paired with health organizations, we can see through that sparse or inaccurate data and resolve those mismatches and duplicates. On average, from our customers, when they first come to us, what we see is about a 30% of their database or data system are mismatches or duplicates. And that's that overlinking, underlinking that we can help resolve with just inputting our data into their system and helping make those matches. So having a data company that sits side by side with the current matching methods proves to be a more effective and efficient approach from both a patient and member safety perspective, but a cost perspective as well. Then once you have what we consider that golden record or record of truth for that patient or member, we assign a unique identifier in our organization. We call it the Lex ID. And that identifier is used across all of our customers. So if you have a patient or a member coming into your system for the very first time, we're able to use our algorithms to link them directly to our Lex ID and to a Lex ID or a record within your system and tell you, yes, it is an existing patient or member in your system, or no, it should be a completely new record, right? But it's extremely important to analyze your current database system, whether it be an EMPI or MDM system, and clean up any mismatches or duplicates and put a process in place so that new records that are input into the system, you're verifying that data and making the accurate match immediately, because good data in means effective and efficient processes down the road. So I don't want to spend an extremely amount of time, more time on this as I want to get to questions, but that's essentially what we at LexisNexis help our customers do, and what we believe that gets people from that 95% rate to 99% or better is just by adding that additional data.
Great. Thank you so much, Courtney. And I'm going to invite the rest of our speakers to come back up online here. And we've got a lot of questions that have come in over time, and we also do have some initially from the prior registration as well. So we're going to get to as many as we can here. All right. So Eric, why don't we start with you? Because I think the physician perspective is really important, and we've got a lot of questions around that piece. And I know that some of the questions actually have to do with what are some of the legal risks around incorrectly matching patient records that you deal with, and the whole idea around medical errors. If you could just speak to that a little bit so people can understand.
Sure, I can certainly take a pass. That said, I'm far from a legal expert, but I would say, this is when I tend to think about medical errors, I like to think of that Swiss cheese concept, right? When all the holes in the cheese line up in the wrong way, something falls through. To think that this isn't going to add a few more holes to that block of cheese, I think would be relatively naive. That said, the risks are, unfortunately, they're pretty obvious, right? If you're hanging the wrong drug on the wrong Bill Smith, and they have an anaphylactic reaction that you can't get them out of, if you're acting off of incorrect information or I suspect that there very well could be a new type of risk related to that, depending upon your state and depending upon where the information was originating from, whether that would fall directly on the provider, on whoever was providing the patient ID that was incorrect in the first place, where it came from. I think that's really, it's sort of very difficult, I think, to answer that with any degree of clarity yet, because I don't think that we really know. It's certainly something that has me, keenly aware and keenly on my toes, and because you don't want to ever make an assumption, right? And that said, and again, I'm very biased to the emergency department because of my background, but it's not just that. If somebody goes on vacation and has to be admitted to the hospital, that information, even if the patient themselves is trying to provide the matching criteria, if they've changed their address and that's what's driving things, then that could be an issue. And I really think about, for example, like a patient who may be on an experimental treatment at one of the larger academic centers who might live remotely or be traveling, things could really get hairy. So I think it's a great point. I don't think I have a great answer to say, well, here's what I expect, other than to say, I think it's going to add a whole lot of new caveats and put a few more holes in the blocks of cheese, if I can go back to that somewhat tired metaphor.
Yeah, and Tesla, I would just ask you to comment on that as well. What are some of the concerns or threats around patient matching, around errors, or just for folks who are kind of new to the conversation?
That's a great question, and we heard a lot of good comments already, but I think it really points to the need for strong data governance principles, and that we have to do as much as we can to ensure data integrity, so that ultimately not only are we technically able to match, but we're doing so in a way that's based on a set of principles or rules that can guide our actions and ensure that we're doing it correctly.
Mm-hmm. And I'd love to hear from all of you. Certainly there's new federal legislation. Courtney, you touched on this a bit in your comments, but what are kind of your hopes in terms of what the federal legislation might do? How positive and optimistic are you about it?
No, so we're extremely positive about it in terms of, we think this is the step in the right direction in terms of interoperability, allowing that record to be commercialized, so each patient, each member has control over their own health record, and it carries with them and transfers with them from provider to provider. We are in hopes that will push forward and get us through to the interoperability that we've been imagining and talking about in the industry for so long. I think that's the ideal state. I think we just need to get through some of the challenges around patient matching, and similar to Desla said, it needs to be around data governance, making sure that record is complete, that we're able to transport it or transmit it from via API in a time that's effective and efficient to make those diagnoses and those decision making at the point of decision making, whether it be in an emergency room or while a patient is on vacation, as Eric mentioned. And then also, as we start to see that the regulation come into play, we're starting to see the healthcare ecosystem open up, right? We have we have technology companies like Google Health and Apple Health coming into the space, and now we're talking about wearable devices and how the metrics that those capture kind of playing into someone's health record and things like that. So I think we're starting to see that ecosystem kind of widen as the regulation starts to play a factor in it. And we're going to have to start to incorporate a lot of what's being captured in terms of metrics into that record system. So we're optimistic about it, but we also know that it's happening rather quickly now, and we just want to stay out in front of it.
Yeah. Desla, anything else you want to comment on that at all?
Well, I think just a little bit to add specifically about the CMS interoperability and patient access rule, and particularly with the payer-to-payer component. So I think we know that providers have great vertical sets of information, individual, pipelines of information about their patients, and where we've had that weakness is across the board in kind of that more longitudinal scope. And I think through the work of the payer-to-payer a set of regulations, we will have at least an early start of clinical information, perhaps not as deep as the clinical information that's held by providers, but we'll have it across the spectrum through the payer-to-payer exchange. So I see this as one of our earliest efforts to finally achieve that idea of longitudinal health records that I know I personally have been hearing about since the early 1980s. And I feel like we now are really starting to make that first step effort. And I think it's a good thing.
We've got a lot of comments in the chat. And I just want everybody to know we are not ignoring you. we see the comments about HL7 and Sequoia and TEFCA. We haven't talked a lot about TEFCA yet, but a lot of good things going on. We know that we're going to try to comment on some of these as we get to them. Desla, you've got a lot of questions here specific. I'm going to just go through just a couple of these. Can you talk about, will you be using the internal, the member? So basically, let me see if I can read this. The member match process. So are you going to be using the currently internal member number to the DaVinci member match process that's recommended for the payer-to-payer exchange?
So the jury is still out on that. I think there is a lot of work still being done to identify the best methods. I think we have a good jump start should that be a way that we head, but we have not made a final determination at this point.
Okay, great. And then one more for you, Desla, before I let you go. Can you talk about the governance infrastructure that specifies an approved use of the master identifier and mechanisms to monitor for prohibited uses? If that's not specific enough for you.
I think we're just talking about the governance. I love that that's what we're talking about here, because so much of everything that's done still lacks that overarching governance principle. And I think that that's where over time we'll be able to see through an organization. For example, I'll use the Sequoia project as an example, as the recognized coordinating entity of TEFCA, to have that solid set of governance principles that we all can abide by will be very useful. So that's one of the things that I think we have great opportunity for greater improvement over time that we've not yet started to address.
Okay. And Courtney, we've got some questions I think would just be help because we've got all levels of folks here on the call here today. So could you just explain, say you have twins with similar names like George Foreman, how do you match kind of dependence if you have sparse data? So just talk a little bit about that, how that works.
Yeah, so with our linking technology, we kind of take the sparse record that is provided, and we have a number of different methods that we use. So we look at historical addresses that we have on file. So in terms of twins, we'll look at credit footprint. We'll look at phone numbers that are associated, emails that are associated. So we have this vast referential database, and where the difference is that where if you take your data within your own system, you could have 6 or 7 of the records within your, we know in our database or our referential database, we have only one record for each and every person. So we have essentially the answer key. And we know that whenever a new record is submitted into us, we're looking for one match and one match only. And so when we do that, we're just looking through our entire database to say, have we seen this address before, whether it be 4 addresses ago or the address that they have today. We look at all of our phone referential databases to say, where has this phone number been associated to? And so we're doing that with each and every single piece of data to kind of help us figure out who that record that was submitted in belongs to within our database. And so we do that, like I said, with a number of different data points, from address to SSN to phone number, email address. And so that's how we are able to, in a roundabout way, use our algorithms to kind of narrow down to who it is, right? What record it belongs to make that match.
Yeah. And Eric, we learned a lot, I think, during COVID-19 about a lot of different things, but certainly the importance of email and mobile phones and how to quickly kind of reach out to patients. Are there any things that you think providers learned during COVID that might apply to this patient matching challenge?
Certainly, I think the opportunities for lessons are endless. And one of the things that springs to to top of mind very quickly for me. And again, I apologize for falling back to my comfortable position as ER doctor as opposed to informaticist. But before COVID, under the way that the EMTALA rules were written, you had to physically perform your screening exam. That changed almost lightning quick overnight when suddenly the ability to evaluate somebody, for example, using an iPad, using an interface, suddenly being able to perform emergency care without necessarily being directly in the room with a patient, which was really, I think people had talked about it at a very high level prior to COVID. And then it was almost overnight that was completely different. So you can sort of imagine how that might lead to different opportunities for this patient matching issue to continue to sort of to have, well, certainly more parameters to consider, right? Somebody could much more easily use somebody else's name, address, phone number. So I think that is, that's certainly a unexpected lesson from an unexpected outcome of an unprecedented problem with COVID. So.
Yeah. Desla or Courtney, you want to add to that? Any lessons from COVID that we could apply to patient matching?
I don't know that there's necessarily lessons. I think it showed, COVID showed the importance, right, of patient matching. You had people being admitted to hospitals that they hadn't been, admitted to before. You had them logging in to patient portals to schedule vaccinations, and for the very first time. And we had no idea, it was the health system's first time seeing them before. I just think, if anything, it showed the importance of patient matching and in terms of the influx of volume that we were seeing from remote transactions and our ability to be able to make those matches. I think it just heightened the importance of it, if anything.
Yeah, if I could expand on that a little bit, I think that's a really great point, Courtney, that the idea of performing telehealth and utilizing portals and apps was not new, but I think we saw a literal boom in a matter of weeks, and I really do think it moved healthcare in whatever direction, depending on your outlook. Personally, I think it was forward, but I mean, it moved us forward, probably. I mean, it's a subjective question, but at least 5 years, if not quite a bit further from where things would have otherwise been, I expect.
And to add to that, I don't know that it's going away, right? I think now that people see the ease and the use of telehealth, I think that it's a trend that's here to stay.
I would agree with that, and at the same time, it does give me a little bit of pause for those who are not well plugged in too, right? Even where it comes to this matching issue, if you have somebody who's been, without any address or who doesn't have any cell phone, if that's going to be our primary driver, what is that going to mean for the indigent? What is that going to mean for somebody who may not be documented? I always think of it as like pulling on a string in a spider web, because it all interconnects.
Jess, I want to give you a chance to jump in here.
Yeah, no, excellent discussion. And really, I don't have anything to add other than I think, we're talking about one small piece in patient matching when there is a much broader process that also needs to occur when we talk about digital identity management and all the information and how it's passed from systems with trust and consent and authorizations and all those other components of this discussion that will have to be a part of a solution that will lead us to effective interoperability over time. So I have nothing more to add. It was a great discussion. I think touched on all the critical points.
Yeah. And I mean, just to piggyback on that a little bit, with these master indexes, certainly with high accuracy, But we certainly saw during COVID, all of a sudden everybody realized all the different digital accounts that they had, all the different digital identities that they had. And I think there was a realization in many cases, oh, you know what, I have 2 accounts where I'm under that name. Or they show up at the doctor's office and they're like, that's not me. Oh, wait, those are both me. How do your organizations deal with that issue now when that comes to play? So somebody shows up in the ER, Eric, and you realize you've got 2 different accounts for them. Or Desla, how are the plans dealing with that?
So I'm going to speak from an old provider's cap here before I am very old, but still very relevant. I think it was previously it was much more likely that that's where the discovery would come, that there had been more than one account, rather than from a payer's perspective. And any type of notification from the consumer would lead to an audit of the existing records and then kick off that kind of reconciliation process of ensuring that you do have one person under one account. I think in the payer community, we will start to see much more of those kinds of recognitions with these upcoming rules that really, they're already effective, but become enforceable starting as early as tomorrow. So I know many of our individual plans have had great focus on developing their consumer response to questions and notifications of this type. So we'll start to see the real impacts here very shortly.
Eric, how about you in the ER there?
Yeah, so I think, it's interesting that you brought that up. And, the last time I was at one of the AHI summits, we discussed specifically Marshfield Clinic. We are a fairly large entity. We have multiple hospitals, and we're currently transitioning to one unified patient record. But it's the idea or the reality that sometimes we have multiple entries for the same person is something that is not unique to, I suspect, most healthcare organizations. It's certainly something that I deal with in my current practice and in previous practices as well. And the short version, the short version of the story is, it's always a little bit cumbersome trying to merge that data and trying to correct that. And the good news for everybody's reassurance is that we're pretty good at being able to take care of the patient in front of us in real time. But how much work behind the scenes with HIM and IT and the providers after the fact to make that one correct record accurately and appropriately reflect what happened can sometimes be a little bit of a daunting task. And I think that's going to be a very ubiquitous experience until we've truly mastered this idea of really mastering the patient matching, even in and amongst health systems, let alone between health systems.
Courtney, you want to add anything?
Sorry, I was on mute. No, I think that's right. I think he touched on everything that I would have said. So. Yep.
Okay. We've had a couple of questions about issues with linking children to parents, which I'm actually interested in as a parent. So what's the skinny on this? Educate me. How does this happen?
No, well, it's difficult. I think everyone in the industry struggles with minors because there isn't a financial footprint there. And so we do at LN, we've developed what we call derived guardian logic, leveraging address, but still very difficult, right, to track or to the records of a minor, right? And so what we tend to do, we've created so we have our Lex ID, which I talked about earlier, but we also have something we developed called customer record key. And what we do with that is for any patient, it might be a minor, it might be someone who has just immigrated over and hasn't really established that footprint yet. Anyone with sparse data, we assign what we call a customer record key according to our customers' data set. And then we will track using that it's a 16-digit code or identifier, and we will track that person with that throughout the life of that customer, as though that customer sees it. So it's not from customer to customer, it's just strictly for that one individual customer header. And what we'll do is we'll track that until they started establishing a footprint to where we could give them a unique ID that can travel with them from customer to customer. So what we do is we try to establish that customer record key until we can assign a Lex ID. But essentially for minors, it's very difficult, but we do have an algorithm that will allow us to connect leveraging name, last name, address to a derived guardian. So we do have that at least, but it's an issue and it's a gap in data that is across the market, right? Minors are extremely difficult to make that match just because of the lack of data available.
Desla, I'm going to guess it's not as difficult with the providers, since, I mean, the payers, because they're linked to the parent, basically.
Interestingly, that is when we think about insurance and family plans and those kinds of things, that is something that's been given great consideration over the time. And something that came to my mind as I was listening to Courtney was, I know that as we were developing our algorithmic rules, thinking about things, how do you distinguish a child on a plan, and using cell phone numbers as an example. There's been a lot of discussion in the industry about potential cell phone numbers as being one of the ways to help distinguish individuals in a patient matching realm. However, we know that children don't always have cell phones. So there are just a lot of different factors that key into this. But I think generally good commentary on the idea of how children are created, or how children are treated in an identity matching situation with plans and payers.
Yeah.
And it's difficult too, if you think about it, not just, to the points Desla made, but also to the point of just because someone is someone's biological parent doesn't necessarily make them a guardian. And so there's certain parameters and risks that come into play when you talk through minors and minors in terms of guardians, right? So.
And if I could build on that, Courtney, even further, when you start considering an emancipated minor and how that data may, transcend, state boundaries, where laws might be different in one state compared to the next. It's truly, it's almost mind-boggling to tackle just that one aspect of all of this. It's really a lot.
It sounds like we could have a whole webinar on the minor issue. I've got about 4 questions about that. So I'm going to say we're probably not going to be able to answer them all today, but we should probably do a special section on this, because this is quite a conundrum here. So a lot of questions about kind of these algorithms, probable matching algorithms, how AI can be used here in matching. Could you guys just comment on that? I think that's fascinating.
I can comment only from, I think, a perspective of what might be useful. There have been some great white papers that have been presented on, probabilistic and deterministic matching and AI and how it's involved. I think I saw in the chat box somebody had put a link to the white paper that BCBSA had worked on with the Sequoia project. There's also a corresponding provider-focused white paper. So I think those might be great resources for understanding the different types of solutions that may be out there.
Yeah. Eric, you want to comment on algorithms, AI, Courtney?
Yeah, I think, from a provider perspective, I think that's one of those, I'm really interested to see what this looks like and means for the provider in the next couple of years. Where I've seen it personally that I think is really exciting is maybe not so much in the direct patient matching realm, but more in the database and population realm in terms of identifying, as we were referring to, social determinants of health. I think there's certainly an opportunity for artificial intelligence to, or I'll just say AI, to really be able to draw some unique conclusions. And I think that's going to be great for driving health. I'd be wary to speak to the algorithm specifically for patient matching, because you're quickly going to, I'll defer to the subject matter experts on that one. But I do think, clearly a role for the provider, and I'm excited to see how that goes.
No, yeah, I think we're still exploring the concept of AI and how that helps specifically the patient matching. I think right now the focus is in terms of, investment. So many healthcare organizations have invested in their current matching capabilities in terms of probabilistic matching, and it's how can we take that initial investment as their engine, and how can we improve what they currently have existing, right? And so if you think about what we call referential matching, we're just pouring oil into that engine to help it run more effectively. And so when we think of AI, we're thinking of building a brand new engine. I think right now with limited spend amongst a lot of the customers that we talk to typically, it's a constraint, right? A financial constraint in terms of investment. And so we're trying to figure out best ways to make their current engine run more smooth. Not to say that AI won't prove itself to be a better way of doing things, but I think the jury is still out on AI. And right now we need something more immediate and cost effective for customers to implement tomorrow, as opposed to 2 to 3 years from now.
How do you think we can better standardize? Gil has a great question here. Standardize the way we talk about matching in terms of metrics, so we can compare apples to apples when we kind of talk about the accuracy of patient matching. Great question. Desla, you want to jump on that?
Actually, it is a great question, because I think if you were to evaluate what accuracy means across multiple organizations, you would get multiple answers. And one of the things when we talk about our accuracy rate, we actually had conducted a study as part of our work that was done with MMI Solution to compare it to the matching accuracy rate of a health information exchange. And it turned out very favorable for us, but we learned in that study, or as part of that research, that there had to be some very precise parameters built around what accuracy really meant. So I think I would say that I don't know that there is a complete solution other than having a definition of accuracy that is adapted across the industry as a whole. And again, I see that as part of that underlying chain of thought around data governance. And how do we know that we're saying the same things in the same way, is because we would be following those guidelines to do so through some data governance principles.
Just about at the top of the hour, so I'd love to give each of you kind of 30 seconds to share some closing remarks or words of wisdom in terms of what needs to happen next, or what you hope is going to happen next in terms of patient matching. And then we'll wrap up. So why don't we just do a quick round robin here. Courtney, why don't we start with you?
I would say just adoption, right? I think I've done several, interviews, in working with customers and interviews in the industry, just to get a finger on the pulse in terms of the market. I think that there's a lot of education that needs to be done. So I think webinars such as these, roundtables such as these, that help educate the market on what possibilities are out there, that probabilistic matching isn't the only way. I think a lot of people believe, it's okay to just be good enough. And I think now what we're seeing is good enough is not great, right? There are other ways to enhance our matching capabilities, and it's time to start investing, right, in those better methods, so that we don't lean on good enough, right? From a patient safety perspective, but also a compliance perspective. So I think what I would love to see is just adoption, right? Adoption and enhancing our current models and methods, so that we see a better outcome. So we're seeing 95%. Well, let's strive for 99, right? Let's push ourselves a little bit that extra to make sure that we're matching to the best of our abilities. So that's what I would really, really like to see within the next, I would say, 12 to 18 months.
Okay, great. Eric.
Yeah, I think I'd echo the adoption comment that Courtney made, but maybe from a different perspective. I'd really love to see the shift being from, this idea amongst providers and systems that, they have the health record for a patient to, as we were saying before, the patients really being stewards of their own information and having the technology and the standards developed to the point where it's easy for them to sort of conglomerate their care, have that record. They're always going to match it better than everybody else, right? So if I can move across the country to California and press my equivalent function of the blue button and send that over via text message to my new doctor, I would love to see that. And I'd love to see that the providers really embrace that idea as well, that this is now a shared two-way communication. And I think there's a lot of exciting developments on the horizon for that.
Okay, and Desla, when I bring
I'll be quick.
No.
I guess I would just like to see, I'd love to see the multitude of brilliant minds that are working on this through the entities that we've heard talked about here, this organization that's sponsoring us on this call today, places like the Karen Alliance, HL7 Sequoia, all of these smart people doing the right things for the benefit of the consumer is in doing it collaboratively so that we're not all going down different roads or the same road in multiple ways. So that idea of collaboration amongst the wide group of people that are working on this, all for the benefit of the consumer, is what I'd like to see.
Great way to wrap us up today. And I do want to just echo that we've had a lot of good information and reports and links shared in the chat. I think what we'll do is we'll go ahead and send those out to everybody who registered for the webinar today, a list of those links and a link to the recording here today so that you can share this with others as well. Really great information. And we're clearly going to have a whole discussion on the minor discussion on patient matching. I saw someone from the Academy of Pediatrics volunteer to help with that. So we will move forward on that. And I want to thank our three really incredible speakers today for just engaging with us and doing such a wonderful job. Thank LexisNexis for supporting the program here today. Great discussion, everybody. Thank you so much for joining us here. Hope you have a wonderful afternoon and stay cool.
Thank you.
Bye.
Bye, everyone.
Thanks, everybody.